We're taking this, 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 we're taking with a pinch of salt.
Dear ladies and gentlemen, welcome to another episode of A Pinch of Salt. Thank you for tuning in and thank you for following us. My name is Andrej Koberné. I'm a nephrologist from Slovenia. In this episode, we're tackling another rare and difficult disease, and this disease is cryoglobulinemic vasculitis. You may expect to hear how we diagnose it, which are the types of cryoglobulinemia and how they differ, which infections are related to the disease, how do we treat it, the possible role of plasma exchange, and much, much more. With us to talk about this is Professor Luca Quartuccio. Luca is a rheumatologist, chief of the rheumatology department in Udine, Italy. Luca was highly recommended to me by my friends from the rheumatology department as a true expert in cryoglobulinemia. So it's a real honor to have you here today, Luca. Welcome to A Pinch of Salt.
Thank you for the introduction. It's my pleasure to be here. Thank you.
Great to have you. Always great to have somebody from outside of nephrology talk about nephrology-related stuff as well, because we both treat these patients. So cryoglobulinemia, as we know, is the presence of cryoglobulins in the serum. These are pathological immunoglobulins that precipitate in the cold. When they precipitate in vessels, they can cause cryoglobulinemic vasculitis. And my first question for you, Luca, would be, how do we diagnose cryoglobulinemic vasculitis, and can we have cryoglobulinemia without vasculitis?
So it's a very good question to start. My answer is absolutely. Diagnosis begins with detecting cryoglobulins in the blood, and it is the first phase of the process of diagnosis, and it's tricky because the sample must be kept warm until clotting and then cooled to precipitate the cryoglobulin. So this preclinical phase is crucial to detect, to find cryoglobulins. And secondly, clinically, we look for, obviously, for signs of palpable purpura, arthralgia, not arthritis. Arthritis is a rare finding. Neuropathy, mainly sensitive neuropathy, as complained by the patient, while the electrophysiological study reveals a sensory motor neuropathy, often sensory motor neuropathy, and obviously hidden involvement, but characterized often by hematuria more than a clear, great proteinuria, such as we find in lupus nephritis, for example. And
so, yeah, go on. Please. Go ahead.
Regarding the lab investigation, the lab investigations are very crucial to diagnosis, and we have to keep in mind that rheumatoid factor and monoclonal component and low C4 are taken together as a surrogate of cryoglobulins, even in the absence of cryoglobulinemia by lab investigation, of course. And clinicians have to repeat the test more than one time if the suspicion is very high. And the last question, cryoglobulinemia without vasculitis. Yes, you can have cryoglobulinemia without vasculitis. Many patients, especially those with type 3 cryoglobulinemia, may be asymptomatic or have mild symptoms, and even healthy people can show transient cryoglobulinemia, mainly during infections, also viral infection or bacterial infections.
Yeah, that's great information. So if I understood you correctly, because the lab testing is so complicated and tricky, you have to consider the cryoglobulinemic vasculitis, even if the cryoglobulins are negative, perhaps, if the clinical picture fits, and if you have rheumatoid factor and low C4. Did I understand correctly?
Yes. It's correct. And also in the case of type 2 cryoglobulinemia, the monoclonal component in the
Okay, exactly. So, so you referred already to type 2, type 3, and obviously there's a type 1. Can you tell me quickly something about these different types and how they differ from each other?
Yes, classically, by the classification of Brouet and colleagues, we classify cryoglobulinemia into three types. Type 1, monoclonal, without rheumatoid factor activity, often linked to hematological disorders, mainly non-Hodgkin lymphoma, but also chronic lymphocytic leukemia or Waldenström macroglobulinemia, more often than in multiple myeloma in our experience. Type 2, mixed monoclonal IgM and polyclonal IgG, commonly seen in hepatitis virus infection in the past, now more often in essential cryo or autoimmune diseases, in particular in Sjogren disease. And finally, type 3, mixed polyclonal IgM against IgG, mainly seen in our experience in autoimmune diseases. And this is a classical classification, but still valid.
Yeah, I was surprised to read in a paper that it cryoglobulin type 3 can transition to type 2. Like in the beginning, you have polyclonal IgM, and then this changes slowly to a monoclonal IgM. I thought it might be, I don't know why I thought it might be the other way around because 3 is bigger than 2, maybe. But so does that transition mean anything in terms of clinics, in terms of therapy? Is it important when this happens?
It's a critical issue. It is not frequent to see this transition from type 3 to type 2, but yes, type 3 can evolve into type 2, reflecting the evolution from a polyclonal proliferation to clonal B-cell expansion. We observe this transition when there is a chronic antigen stimulation, such as in hepatitis C virus infection, but also in Sjogren disease. And this transition is clinically relevant because type 2 is more aggressive, reflects a more aggressive disease, and more likely to cause vasculitis, and more linked to lymphoma occurrence over time.
Yeah, that is important, of course. I also saw one patient once go from type 1 to type 3, actually. So initially it was a monoclonal antibody and nothing else. But then he developed, it seems like, an essential cryoglobulinemia out of that. And first he responded to clone-directed therapy, bortezomib, and then he responded poorly to that, but good to rituximab. Have you ever seen anything like that? That was a surprise to me.
Very surprised situation. We did not see such case, but we often see type 1 cryoglobulinemia. We defined these cases as monoclonal gammopathy of clinical significance, because these patients do not have an overt lymphoma or other clear hematologic malignancies, but have a bad small clone that produce a very high level of damage in the organs.
Yeah, the bad clone. Good. So let's move on to infection now. I'm always paranoid about treating patients with autoimmune diseases that have secondary autoimmune diseases with immunosuppressive therapy. We once had a patient who had a bad case of IgA vasculitis, very significant kidney disease. She was a drug addict. We treated her with steroids in the end to find out that she has spondylodiscitis, which was very very low symptoms because she was on methadone all the time. So how are we sure that cryoglobulinemia is not because of an infection? How do we diagnose? What do we do in the panel? What do we diagnose?
So still in this period, the most common infectious trigger is hepatitis C. 50% now of the etiologies in the last 10 years in our experience. So we start with searching anti-HCV antibodies and then HCV RNA by PCR. Regarding hepatitis B, we check for surface antigen for hepatitis B, and also antibodies against the core antigen and HBV DNA. We also look for HIV, EBV virus, CMV virus, and even B19 parvovirus may be considered based on the clinical context and the recent increase in the prevalence in Europe of these infections.
Yeah, that's good. That's what I wanted to know. Do you check also EBV, CMV, and
Yes.
B19 every time? Okay, that's good to know. Okay, great. So in patients who have hepatitis C and cryoglobulinemic vasculitis, when do you start with immunosuppression immediately along with antiviral therapy? Or when do you just start with antiviral therapy and not with the immunosuppression therapy? How do you decide?
Absolutely good question. In the case of HCV, if the patient has severe or life-threatening organ involvement, such as glomerulonephritis, rapidly progressive nephritis, severe motor neuropathy, or CNS vasculitis, we immediately start great immunosuppression with rituximab, but also rituximab plus plasma exchange, or rituximab plus cyclophosphamide, and then in the second period, the antiviral treatment. Or in moderate cases, we can start rituximab together with antivirals, together with DAA. So, you know, rituximab is often used, sometimes with the corticosteroids. We do not use corticosteroids, only we use corticosteroids only with high doses in the case of major organ involvement. If no major organ involvement, we do not use corticosteroids. Even low doses, we do not use low doses, chronic low doses of corticosteroids in HCV-related cryovasculitis, but also in the other cryovasculitis. And antiviral therapy should not be delayed, but in severe cases, both treatments can be initiated concurrently. Most important, in the case of HCV infection, immunosuppression must be applied, but always in combination with antivirals for hepatitis B, due to the very high risk of acute HBV reactivation with high risk of mortality, in particular under rituximab.
Yeah, that's interesting to know. So you don't actually use steroids unless it's really life-threatening or organ-threatening.
In life-threatening, yes.
In life-threatening, yes, of course.
Yes,
yeah.
but in mild and moderate cases, we do not use corticosteroids, only rituximab, because cryoglobulinemia is a lymphoproliferative disease.
True, yeah, that's true. And it has been shown that corticosteroids can worsen hepatitis C infection.
Yes.
And that makes sense then. And rituximab doesn't really worsen hepatitis C that much, but hepatitis B definitely. So
absolutely.
Yeah. Definitely need hepatitis B therapy if you have hepatitis B. So you've mentioned plasma exchange. So do you do plasma exchange in these cases?
Yes, plasma exchange is reserved in our experience for severe cases. cases of hyperviscosity syndrome. It is rare, very rare in type 2 and type 3, more common in type 1. Also in rapidly progressive glomerulonephritis or refractory vasculitis, or even when rituximab is contraindicated. For example, in the case of cryoglobulinemia and concurrent infection, for example. Maybe during COVID infection, we saw a patient with cryovasculitis and COVID-19 infection. So we first treated this patient with plasma exchange, and then after infection with rituximab, for example. We typically perform 7 sessions over 2 weeks, often alongside with the rituximab, plasma exchange, and then rituximab after at least 72 hours from plasma exchange, due to the possibility to eliminate rituximab by plasma exchange. And replacement fluid is usually with albumin, unless plasma is needed for coagulation support, in particular in the case of alveolar hemorrhage.
Yeah, that makes sense. Yeah. So I was interested in that. How do you give rituximab if you do plasma exchange? Because with plasma exchange, you eliminate the rituximab. So do you start it after you've finished all the 7 procedures, or do you still give it in the beginning and then add something later on? How do you give rituximab?
The best way is to use rituximab in the absence of plasma exchange, because plasma exchange eliminates rituximab in part. Not all rituximab, but it may be possible. When we need to use combination rituximab plus plasma exchange, we perform 1 session plasma exchange and then rituximab at least after 72 hours. And then again plasma exchange, and then after rituximab after 72 hours.
Okay, that seems kind of strange to me, because why would you have to wait for 72 hours after the plasma exchange? You could, in my opinion, probably give it immediately after the plasma exchange, because the plasma exchange will not be taking it out. What makes sense probably to me is that when you give it, you wait 72 hours for the next plasma exchange. Is that?
Yes, of course.
That's what you meant.
Wrong.
Okay.
I was wrong.
Okay. That makes
Sorry.
No. Maybe maybe I misunderstood. That's fine. Okay.
Rituximab and then a plasma exchange. Okay.
Yeah. Okay.
Yes.
That clears it up. So 70 hours to the next plasma exchange. Okay.
Yes.
Yeah. Great. Yeah. It was sometimes we give cyclophosphamide because to cover this period of 2 weeks, when the rituximab dosing is not so optimal, we sometimes do that to solve this problem. So how about type 1? Oh, sorry, you wanted to add something?
It is the same for us.
Okay,
the same for us when we use a rheumatologic scheme of rituximab infusion. But we combine rituximab and cyclophosphamide only in life-threatening situations.
Yeah, of course. That's the ones that you do plasma exchange anyway. Yeah. Okay. We clear that up. So how about type 1? You already said that that's related to monoclonal disease, more oftentimes lymphocytes than plasma cells. And how do you treat that yourself? Is that the hematologist treating the patient? How does that happen in your case? And what's your experience? How good is how well do they respond to treatment and the long-term prognosis of these patients?
So we know that IgG subtype and patient with monoclonal gammopathy of renal significance show the worst prognosis. So, as a rheumatologist, we intercept sometimes these patients, and we try to treat them with cyclophosphamide and plasma exchange. But I know that the best treatments are in the hand of hematologists for these diseases.
So you transfer them to hematology,
yes.
and
Yes.
do you have any follow-up then long term? What happens to these patients, or
no, because there is a follow-up only in the end of our colleagues.
Yeah. Because what I've seen, they respond to treatment, but they relapse very often afterwards because of the clone, right? And which is not the case so much in type 2, type 3, right? It's not often the case. Often they do not relapse. So do you give any maintenance treatment?
Yes, we know that a patient with essential cryo and Sjogren disease associated cryo often relapse. So we apply a maintenance treatment with rituximab every 6 to 12 months.
Is that for a couple of years or longer than that?
Usually 2 to 3 years.
Oh yeah, and with essential cryoglobulinemia, do you give maintenance with essential, not
Yes.
secondary to Sjogren?
For both essential and Sjogren's.
Oh, so even in idiopathic essential,
Yes.
you give maintenance. Okay.
Yes.
Okay, good to know. So is there anything new on the horizon for cryoglobulinemia? This is a complement therapy now is anti-complement therapy is very popular now in nephrology, and this is obviously a complement related disease, but as far as I know, that hasn't been really successful in cryoglobulinemia. Anything else on the horizon?
I know only a single case published on the use of eculizumab in cryovasculitis, but this patient responded to plasma exchange
Yeah, exactly.
than to eculizumab. So the complement is important in the pathogenesis of the disease, but I think it is not a good target.
Yeah, it seems so. Yeah, it seems so. It hasn't taken off.
I think more other options, in my opinion, and also in our experience, are other anti-CD20 monoclonal antibodies, such as obinutuzumab, or we used ofatumumab in the past in a patient with cryo and Sjogren and lymphoma, for example.
Yeah. Okay, yeah, that we've had some experience with that too. Okay, good. Very nice information, very nice clinical experiences.
And also we apply a combination between rituximab and belimumab in refractory cases of type 2 cryovasculitis.
Oh, that's good. I haven't heard about that. That's good to know. Okay. Okay, so now we came to the last question, which is not cryo related, but more about you as a person. And this is which book, 2 songs, and luxury item would you take to a desert island?
So wonderful, wonderful. So as book, I take a Game of Thrones, since I've watched the series. I'd love the time to explore the rich world of the books it's based on.
Rich and brutal world.
Yes, brutal, but wonderful series. Wonderful series.
Okay.
I have a picture of the series in my
Oh,
house.
yeah. A poster.
A poster.
Like we had rock groups on the wall when we were young. Yeah, that's great. Okay, what about
A poster
songs?
of Daenerys.
Yeah. Oh, of course. Makes sense. I understand.
And also for music, I'm Still Standing by Elton John, because
Oh,
its message of resilience is essential in today's world, I think.
yeah. That's a good song for when you're at the hospital during the night on call, right?
Yes.
I'm still standing.
Absolutely agree.
Okay. And what about the second one?
The second one, Bach's Brandenburg concerts.
Ah, okay.
Timeless, intricate, endlessly inspiring. Yes.
Yeah, we've had some Bach fans already on
Ah,
our episodes. Yeah, somebody picked the Goldberg variations, and
yes.
so we've had some Bach fans. Yeah,
Played by Glenn Gould.
yeah, we talked about too. Yeah, but I think it was it from Goulda that the person preferred? I can't remember right now. But yeah, Glenn Gould is it.
Ramin, I heard Ramin Barami, for example,
Ah, okay.
playing. He was in Udine 2 years ago.
Oh, you heard it live.
Yes,
Oh,
yes.
that's so special. Nice, very nice. You should come to Slovenia, to Ljubljana. We have a great concert season this year.
Ah,
Yeah, we have Arvo Pärt, which I've been
wow.
waiting. Yeah, I've been waiting to hear Arvo Pärt live for years, and this year we have three pieces, so I'm really excited.
Yeah.
Good. And luxury item for the desert island.
Oh, yeah. I don't know it exists, but a solar powered espresso machine.
Ah, Luca, you're truly Italian. Un italiano vero. Okay,
For making creamy cappuccino, latte macchiato, lots of foam.
okay, I
Good
accept that.
coffee is not negotiable.
Yeah, not non-negotiable. Very good,
Non-negotiable,
very
yes.
good. Thank you very much, Luca, for joining us for this episode. Thank you for sharing your valuable experience. We've been very lucky to have you.
It's a
So,
pleasure,
bye
very
bye.
pleasure for me. Goodbye.
Bye bye.
Bye bye.